Hello, good evening, everybody. Today we are going to start discussion about upper GIT surgical problems. We will solve together eMRCS 2020. Okay. So let's start our first question, Dr. Nuran. Okay.
A 45-year-old man with recurrent episodes of confusion is found to have a 1.5 centimeters insulinoma of the pancreatic head. What's the most appropriate management? A. Whipple procedure. B. Total pancreatectomy and the en bloc splenectomy. C. Pylorus preserving pancreaticoduodenectomy. D. Inoculation of the lesion. E. External beam radiotherapy. B. Total pancreatectomy.
Total pancreatectomy for 1.5 centimeter insulinoma.
D. Inoculation.
Okay. Yes, I know upper or GIT is somewhat difficult or not common. I would not say difficult, but I'd say it's not a common practice for most of non-surgeons. And even in some branches like hepatobiliary and more specialized branches like hepatobiliary, colorectal, and something like this is not more common, but we will try to make it easy as we can. Okay, so right, inoculation. Insulinoma is benign tumor, and most benign tumors maybe well circumscribed, and it's easy to inoculate and remove without removal of the whole pancreas, so the patient can live without pancreas. Okay, we only remove the total or subtotal pancreatectomy in some diseases like hyperinsulinemia, without knowing the cause or without knowing the source. Okay, and this is very rare patients. By the way, that you have a patient with high insulin level in blood, and you search by all your methods, PET scan and isotope and ultrasound, endoluminal ultrasound, and serial MRI and multi-slice CT, and you can't find where exactly coming this insulin. So they go for about 80 to 90% subtotal pancreatectomy, and they see dramatic response, and the patient starts to have low insulin level, and this so relate to maybe generalized increase in pancreas secretion for insulin. I know a patient, by the way, had this problem, and she's a child about 2 years, and I discussed this problem with many endocrine surgeons in UK and USA, and they told us that maybe in their life they see about 5 to 6 cases about this. So total or subtotal pancreatectomy, we use it high insulin level, but generalized high insulin level, not just a small insulinoma. Okay. Okay. Next question, doctor.
A 56-year-old man admitted with the diffuse upper GI intestinal hemorrhage. He is relatively malnourishment, and he has evidence of the gynecomastia. An upper GIT endoscope is performed, and view are limited because of the extensive amount of the bleeding. What is the most likely underlying cause? Barhow perforation, miliary waist tear, esophageal varices, esophageal carcinoma, esophagitis. It is esophageal varices because it is, yeah, you see.
Okay, so what's your?
Because
yes,
it is
thank you.
because it is gynecomastia, it is related to the liver disease, So with the bleeding,
Okay.
varicose vein, varicose vein. Okay.
Okay, so the keyword here is gynecomastia, and the gynecomastia doesn't happen with normal esophagitis or cancer or Mallory Weiss-Ter or Burhive perforation. Okay,
Also, other key
so
points: profuse bleeding.
profuse bleeding.
Yeah, because the other.
Yes, it is not common with cancer. It is not common with esophagitis, but may happen sometimes with Burhive perforation, or some perforation may happen from the azygous vein. So most commonly will be esophageal varices. Really, it's the most or the most copious bleeding happens from varicose veins. Because this patient is hepatic and have portal hypertension complicated with esophageal varices and bleeding. That's why he have gynecomastia. Okay, next question. Dr. Basharat.
Can I go?
Okay, Dr. Ibrahim, yes, go, please.
35 years old man present with dyspepsia, upper GI endoscope. He has punched out ulcer on the nasal curvature of the stomach. It's measured approximately 2 centimeters in diameter and is seen in penetrating the muscle with fibrosis present at the base. What's most likely diagnosis? Chronic ulcer, Cushing ulcer, chronic ulcer, adenocarcinoma, gastric lymphoma. I think it is it's chronic ulcer.
Yes, so what's your keyword here?
There is 2 centimeter in diameter in this curvature and this fibrosis.
Perfect. Fibrosis is your keyword here. Fibrosis is the keyword here, and eMRCS or in eMRCS exam. Just you want you to make differentiation between chronic ulcer and acute ulcer. Both of them have the site of lesser curvature, and this is the normal or the most common site for peptic ulcer. It's almost punched out. If he didn't tell you, just tell you that it's shallow, so it will be an acute ulcer. If he tell you it's fibrotic with evidence of fibrosis penetrating the muscle, so it is a chronic ulcer. And this is the most common 2 questions that you will face about ulcer or peptic ulcer. He just wants, if he didn't mention fibrosis, go for acute. If he didn't mention if he mentioned fibrosis, go for chronic. If he mentioned any problem like cachexia, dyspepsia, loss of weight, or any manifestation from malignancy, you will go for malignant ulcer. And I didn't see any question with malignant ulcer through my revision for recalls even. Okay.
Okay.
Okay. Next question.
Should I start?
Okay, Dr. Fatima, if you want to start or to participate, you can raise hand, please. Okay, Dr. Nuran, go.
A 76-year-old man presents with a 5-week history of dysphagia. An upper GI performed, and the surgeon notices changes that are compatible with Barrett's esophagus. The esophagus is filled with food debris that cannot be cleared, and the endoscope encounters a resistance that cannot be passed. What is the most likely underlying diagnosis? A. Adenocarcinoma. B. Squamous cell carcinoma. C. Achalasia of the cardia. D. Nutcracker esophagus. E. Benign peptic stricture. Okay, progressive dysphagia. Barrett's suggests adenocarcinoma. but I don't understand why he'd mention stricture and such. Not cracker esophagus?
No.
Then
You said
adenocarcinoma.
try to different. So yes, adenocarcinoma. Okay, don't just the first answer mostly, not always will be the right answer. Okay, let's say this is an old patient, short history of progressive dysphagia for just five weeks and progressive. So it is a rapidly growing disease or mass. Okay, so this is the first one. So this is something rapidly progressing. Upper GI endoscopy performed, and the surgeon noticed change in that are compatible with Barrett's esophagus. So we have Barrett's esophagus. The esophagus filled with food debris and can't clear it, and endoscope encounter a resistance. Okay, this patient doing an elective upper GI. Okay, this patient just had dysphagia, and he did elective upper GI. Maybe he overnight fasting, and although he is about 8 hours fasting, still some foods that can't pass. If we can remember, we have two types of strictures that can pass food and fluid. Okay, we have what's called achalasia and what's called malignant stricture. Achalasia, only fluids can pass, but hard food or food can pass and make dilatation of the sphincter and pass, but fluids not easy to pass, and you always find the esophagus full of bad smell fluid from the resistance of the sphincter for passing fluid. The other one is not just passing fluid, because it is not closure, it is not spasm, just narrowing. And so fluids can pass, but food can't pass because it's a firm stricture. So it is mostly will be a malignant stricture. Okay, so we agree that's a malignant stricture. We have two malignancy. This is approach of solving the risk. We have two malignancy, very common in the esophagus. One of them is the adenocarcinoma, and the keyword is Barrett's esophagus or long history of GERD and heartburn. The other keyword for squamous cell carcinoma is achalasia, is always complicated by squamous cell carcinoma. So the history here goes with malignancy, and I have to choose between adenocarcinoma and squamous cell carcinoma. Not going with achalasia for sure. So I go back for the scenario. I'll find Barrett's esophagus, so I'll go direct for adenocarcinoma. Okay, is it clear?
Yes.
Okay, we have to go in two ways: achalasia, malignant. If malignant, I have to ways adenocarcinoma or squamous cell carcinoma, and this is all what we have to diagnose any stricture in the lower esophagus. And we have another one, but it's very rare, and it's not a very common question. We will face it soon during our discussion. Okay, next question, Dr. Dafer.
Okay.
Go.
82 years old man presented with the dysphagia. He is investigated and found to have adenocarcinoma of distal esophagus. His stage investigation have revealed Mercury metastatic lesion in the right lobe of the liver. What is the best course of action? Arrangement for CT scan, arrangement for endoscopic ultrasound, assessment, fitness for liver resection prior esophagectomy, assessment, fitness for esophagelectomy, followed by liver resection, inserting of metal stent, DAE. Inserting of the metal stent, because it is metastasized to the liver, is outside of the esophagus, is palliative. And also the age, it's high age group.
Perfect. Yes, here. any metastatic esophageal cancer, go for palliative treatment. The palliative treatment he wants you to know here is just go for stent, no dilatation. Okay, you have two ways for any stricture in the esophagus. If it is benign stricture, we'll go for balloon dilatation. I repeat again, if it is benign stricture, we will go for balloon dilatation. If it is malignant stricture with extra esophageal metastasis, so go for palliative treatment through metallic stent. Okay?
Okay. I add some things. Esophageal metastasis to the liver, palliative. Rectal, colorectal carcinoma, metastasis to the liver, treatment surgery sometimes. Okay.
Okay, minute please. Okay, so thank you. Next question, please.
There is 35 years old man is admitted with episodes of collapse and passage of melena. He has been suffering from postprandial abdominal pain for 5 weeks, and this is most marked several hours after eating. What's the most likely cause? Anterior duodenal ulcer, posterior duodenal ulcer, esophageal varices, urology lesion, carcinoma of stomach.
What is this clinical picture?
It's picture of
What
duodenal
is the
ulcer.
clinical picture from? Exactly. So it is
Is it
postprandial
pain with
abdominal pain
pain? Yeah.
for a time. Well, most marked several hours after eating. Okay, after passage of acid chyme to the ulcer, he will feel the pain. So this is a picture of duodenal ulcer. It is anterior or posterior?
Posterior, yeah. It's melena. Most commonly with posterior. If I choose, I will choose
Yeah.
B.
Yeah.
Posterior duodenal ulcer.
Yes. Okay. Most common way is posterior. From which artery?
Paediatric.
Posterior from gastroduodenal.
Gastroduodenal, exactly. Gastroduodenal artery. I sent a photo about this before. Gastroduodenal artery pass behind the second part of the duodenum, and it's a common question in the anatomy. Okay, and the abdomen branch, posterior relation of the one of the following is posterior relation to the duodenum is the gastroduodenal artery, and it's the most important. It is the most important artery because it's when there is duodenal ulcer perforation, this artery will have bleeding. But if it is an anterior duodenal ulcer and have perforation, what will happen?
Anterior duodenal perforation.
I can't.
Where will open?
So open in the peritoneum.
Peritoneum. So peritonitis will happen.
Yes.
Okay. The duodenum is a retroperitoneal structure. So posteriorly will open in the retroperitoneal, anteriorly will perforate the peritoneum and make peritonitis. Okay, and it's a very rare ulcer, mostly will be posterior duodenal ulcer. Okay, so what's your management for bleeding duodenal ulcer? Posterior duodenal ulcer, bleeding now, and you have the patient. What's your management? Anyone know?
First, yes.
Adrenaline injection, I think.
This is the first step. If not, respond. If not, respond for adrenaline. Okay, Dr. Nuran.
I was going to start earlier to say management first.
Sorry?
The patient is shocked from the bleeding. First, resuscitate the patient.
Okay, I'm just thinking about the definite management. Thank you, really. Definite management of this of the bleeding ulcer. He said adrenaline injection, but if the patient doesn't respond, what I will do?
The running sutures of the, I think.
Okay, laparotomy and under-running suturing of the bleeding ulcer. Okay, this is the 2 steps. You have to start with the first one, followed by the second one. Okay?
Okay.
Clear? Okay, next question. Dr. Nuran.
A 45-year-old man undergoes an upper gastrointestinal endoscopy for a benign esophageal stricture. This is dilated and suffers a nephrogenic perforation at the site. His imaging shows a small contained leak and a small amount of surgical emphysema. What's the most appropriate nutrition? A, nil by mouth and fluids alone. B, intravenous fluids and something orally. C, total parenteral nutrition. D, and sips orally. Okay. C, total parenteral nutrition. D, nasogastric feeding. E, peg tube feeding. Surgical emphysema necessitates nil by mouth.
Okay.
And this is, I think that this is something that can be managed, and so you cannot give total parenteral nutrition. It needs to be for longer periods of time.
Okay, and this person, is it expected to take long time till the perforation close?
No.
How come? How come? We are giving IV fluids up to 5 days maximum. We can't give more than this. After the 5th day, you have to, or sometimes less than, you have to give full formula for the patient. Is it expected to go close within 5 days?
No.
Perforation? Okay, so the first choice, IV fluids alone, is not accepted. Okay.
Yeah.
So go for the next one, IV fluids and sips orally, and this is catastrophic, completely contraindicated. I don't give sips orally, so it will never close. Total parenteral nutrition, maybe, yes, maybe. Okay, I can give it, maybe take 10 days, 2 weeks. This is a small leaking perforation, so it may take time. So as long as I am depending on total parenteral nutrition, so I have no problem, maybe 3 weeks, 4 weeks, no problem. Nasogastric tube, is it safe to put a nasogastric tube in patient have a perforated esophagus?
No, you might increase the injury.
May increase injury, and may, if it passed safe, if you try to inject or to give any food, it may, the patient is during movement, during sleeping, if any GERD happened or any backflow of food or some fluids happen, it makes the problem worse. and this is also for the percutaneous endoscopic gastrostomy. Any food or any drinks go for the stomach. If you have any problem in the esophagus, it may make the problem hazard. You are scared from GERD or back aspiration from the stomach to the esophagus. So you have to go away from this. One more option maybe, so total parenteral nutrition will be the most acceptable here. For me, before reading the answer, I answered jejunostomy. If I want to do, I can do jejunostomy tube. And this is more acceptable than total parenteral nutrition, and I think for me. Anyone agree with me?
I agree with that because it can be used for a long time, no reflex, and avoid the complication of
Exactly. Any esophageal problem, I always go for a jejunostomy, and it's safe and no backflow and no GERD, and I can depend on it for a long time without any complication, and avoid the complication of total parenteral nutrition for this minor injury. I know it is a surgery, but it can be revised simply without any complication. Okay.
Okay.
I need some comments. I believe that if the gut is available, it should be used exactly. Ajay, you can do endoscopic, nasogastric, tube, insertion into the duodenum. Yes. Also, it can be slept because you have long time. You are giving more than 2 weeks putting a tube, nasogastric or nasojejunal is not accepted. The complication of dislodgement and complication of displacement is very common, and it may take more than 2 weeks, so it is not logic.
Also, the endoscope maybe aggravate the trauma.
Exactly.
And will disrupt
exactly.
it for that.
Anything you want to do, you will do it percutaneous, by the way.
Okay.
Percutaneous jejunostomy, percutaneous gastrostomy, if it is acceptable, but you will not go through the esophagus by any instrument.
I have to think that any esophageal injury, you should go to jejunostomy or TBN. I think.
Exactly. If we found here jejunostomy in the answer, it will be more logic than TBN, by the way.
Yeah.
Okay.
Okay.
Next question. Dr. Fatima, are you ready to participate with us?
Hi.
Okay, go ahead.
Sure. 88 years old woman undergoes a gastric bypass procedure. Post-operatively, she attends the clinic and complains that following a meal, she develops vertigo and develops crampy abdominal pain. What is the most likely underlying explanation? Insulin resistance, irritable bowel syndrome, biliary colic, dumping syndrome, and enterogastric reflux. So as she has a gastric bypass procedure, so it will be dumping syndrome.
Exactly, and she has developed crampy abdominal vertigo and crampy abdominal wall. Which type of dumping here?
The details I don't know.
Type 2.
Sorry?
Type 2 lid dumping.
No, it is early dumping.
Early?
Yes.
Okay.
Okay, yes, like Ajay. Okay, we have early dumping. Yes, exactly. Dumping syndrome is a very common complication from any gastric reduction surgery or gastric bypass surgery. Any reduction in the stomach size by bypass, like bariatric surgery or distal or subtotal gastrectomy in cancer or any problem, and you make, or you just to make maybe a Pilros, or you go for any improvement for drainage for the stomach that makes the stomach empty more faster than normal, you will go for what is we call dumping syndrome. What is dumping syndrome? Simply, we have two types of dumping: early dumping and late dumping. Early dumping happened when the passage of hyperosmolar food rapid from the stomach to the jejunum in a short time, and it's very high osmolarity. This high osmolarity will absorb water from the fluids, from the extracellular fluid in the vessels and in the body, and it will decrease the venous return and decrease the blood pressure, and the patient will feel like dizzy and vertigo. Okay, because the fluid moved from the extracellular fluid to the or from the body extracellular and intercellular direct to the intraluminal, and the patient feel like crampy and bloatness of abdomen and gurgling sensation and distension, because the lumen of the jejunum and the small intestine is full with fluid from the body, and the patient start to feel dizzy. Late dumping happen after the passage the same. What will happen here is that the high glucose content of the food, especially this late dumping, by the way, happened only with some starch or not with all food. Doesn't happen with protein, doesn't happen with fat. What happened if you eat food with a high glucose content or starch or carbohydrates? The high glucose content of the food start to make the pancreas to secrete more amount of insulin to decrease the glucose level of the blood, and this will be followed by hypoglycemia, which will cause late dumping, which is hypoglycemia following the hyperglycemia that triggered the increase in the insulin level in the blood. Okay?
Okay.
So the early one is abdominal cramps and vertigo, early because hyperosmolarity. The second or the late dumping is due to hypoglycemia. Clear?
Okay. Clear.
Okay, next question. Dr. Dafer.
Okay. 63 years old man undergo upper GI endoscope and adrenaline injection for a large active bleeding duodenal ulcer. He remained stable for 6 hours and nurse then called because he has passed 400 ml of melena and he has become tachycardia, pulse rate 120 and hypotensive blood pressure 80/40. What is the best option? Reassurance the patient tapping in the upper part of the gastrointestinal system will pass. But that is the episode resolved spontaneously. It's not. Perform repeated upper GIT endoscope. Not. Perform laparotomy and undermining the runnings of the ulcer. This is true. Administration of the tranexamic acid. No. Inserted of the Mann-Sota tube. No. So it is C.
Yes, exactly. We just talked about this a few minutes ago. Okay. First step in treatment of bleeding duodenal ulcer is adrenal injection. Okay. If it is not successful, you go for laparotomy and undermining or underrunning the ulcer. Okay, so our answer: perform a laparotomy and underrunning the ulcer. Next question, Ibrahim.
Okay. 55 years old, a man present with symptoms of dyspepsia and upper GI endoscopy, an area of patchy synthes tissue, identified extending proximally from gastroesophageal junction. Biopsy is diagnostic of Parrot's esophagus with low-grade dysplasia. Which of the following most appropriate next step? Distal esophagectomy, upper GI endoscopy, and quadrant biopsy of the region, photodynamic therapy, endoscopic submucosal resection of the area, argon plasma coagulation. I think it's B, upper GI endoscopy and quadrant biopsy from the region.
Yes, I think we have a short discussion about this question a few weeks ago. Okay, you have three scenarios here in doing an upper endoscopy and to find some abnormality in the gastroesophageal junction. The first one, you will find a low-grade dysplasia. Okay, and this you will go direct for quadrant biopsy or quadrantic biopsy from this region. Okay, this next scenario or the second scenario, he will tell you he found a high grade dysplasia, or sometimes he tell you a T1 staging. Okay, high grade dysplasia or T1 staging. T1 staging means it is limited to the mucosa. So both of them have one treatment option, which is endoscopic mucosal resection. Okay.
Yeah.
Submucosal resection, submucosal endoscopic, submucosal resection. Okay. The third scenario that you'll have criteria of malignancy, advanced malignancy at the gastroesophageal junction on top of Parrot esophagus with no extraesophageal metastasis, and in that you will go for
surgical
esophagectomy. Okay, and the last scenario is you found cancer plus mets, and we answered this. You will go for palliative treatment by stent if there is a stricture. Okay.
Okay.
Clear all the scenarios about findings and the gastroesophageal junction. This is all the scenarios you will face today. Clear?
Okay.
Yeah, clear.
Okay, next question. Dr. Nuran.
A 62-year-old man presents with dyspepsia and the tumor of the gastric cardia is diagnosed. He has no evidence of metastatic disease. What's the most appropriate treatment option? Okay, before reading, this should undergo esophagectomy. Gastric cardia, gastrectomy. So total gastrectomy, row on Y, total gastrectomy, and row on Y, reconstruction, total gastrectomy, and loop jejunostomy reconstruction. The proximal gastrectomy and gastric pull-up, external beam radical radiotherapy. 62 gastric cardia. Total gastrectomy. I'm a bit concerned about his age.
Okay. This, by the way, 62, this is young age in UK.
Okay.
Old age start after 80. Okay, so, okay. Where is it? Where is the tumor?
In the cardiac.
In the cardiac. Okay, so
I think total gastrectomy. I think.
Okay, so total gastrectomy was loop jejunostomy or was row and Y?
Row and Y.
Row and Y, exactly. Okay, any tumor in the stomach, in a distance less than 5 to 10 centimeters, we say 10 centimeters from the gastroesophageal junction, you will go for total gastrectomy. Okay, if the tumor is after or distal than 10 centimeter from the gastroesophageal junction distal to that, you can just preserve the stump of the stomach to make anastomosis with it, and this sometimes what happens in gastric bypass operations. We just preserve a small cuff of the stomach for the gastric bypass. Okay, loop jejunostomy is not a common practice. We always do after the gastrectomy through. We go for Roux-en-Y reconstruction. Proximal gastrectomy, no, we don't do this. We just do, even we do total or distal gastrectomy. Proximal gastrectomy is not a common practice. External beam radiation, no, this is no metastasis, so we go for surgery. It is not a palliative treatment. Subtotal gastrectomy, we don't do subtotal gastrectomy in tumors less than 10 centimeters from the gastroesophageal junction. So our answer will be total gastrectomy and performing a Roux-en-Y reconstruction. Okay?
Okay.
Okay.
Next question, Dr. Fatima.
Yeah. So a 45 years old man has been troubled with dysphagia for many years. He is known to have achalasia and has had numerous dilatations. Over the past weeks, his dysphagia has worsened. At endoscopy, a fibril mass is noted in the esophagus. What is the most likely diagnosis?
Achalasia means.
So, is it squamous cell because he has achalasia?
Exactly. Okay, as we go for our algorithm, I'm just talking about two problems that make stricture: dysphagia, achalasia, and Barrett's esophagus with cancer. Okay. Achalasia, if he tell me that progressive dysphagia over 6 weeks and the last scenario was 5 weeks progressive dysphagia, so we are going to cancer. 5 weeks or 6 weeks progressive dysphagia, we are going to cancer. So go back for the question, which type of cancer of the esophagus we will see? If he mentioned achalasia, so we will go for squamous cell carcinoma. If he mentioned on top of Parrot's esophagus, so we will go for adenocarcinoma. Okay, so it is squamous cell carcinoma on top of
Reverse
achalasia.
the A. Reverse the A.
Sorry?
Reverse the A. Squamous with the achalasia. Reverse.
Yes.
Okay. Adenocarcinoma with the GERD.
Okay. Reverse the A, exactly. Okay, no A with A.
Yeah.
Thank you, Dr. Daf.
Thank you very much.
Okay, next question, Dr. Daffer.
Okay. A 58 years old lady has 2-year history of the worsening dysphagia. In addition to this, she has an nocturnal cup. Over this time, he has lost totally 8 kilograms in the weight. Which of the process below is the most likely explain for this gastroesophageal disease? Is Barrett esophagus, is carcinoma, miliary ways, and achalasia. So it is a worsening dysphagia. I goes with the nocturnal cuff. I goes with the achalasia, E.
Achalasia.
But like if there is a weight loss, so in achalasia there is so much weight loss, like 8 kg.
Okay, you go with Dr. Fatima.
Carcinoma.
carcinoma over 2 years?
Over 2
No.
Oh, it's over 2 years. No.
Here's a
Okay, I just
that's
mentioned
carcinoma.
carcinoma. I'm just doing the question with you, but I'm just thinking yes. Dr. Fatima, you're right. Yes, worsening dysphagia in addition to just let's read the explanation here. Just marked weight plus aroused suspicion of cancer. She is most likely to have a long-standing stricture associated with esophagitis or Barrett's esophagus. This may progress to carcinoma, which will tend to occur in association with worsening dysphagia and weight loss. Nocturnal cough. Over this time, she lost over the 2 years, she lost 8 kilo in weight, which process will be the most likely explanation for this. By the way, this is not clear questions, and I think it will not to be a common question in the exam. Questions will be more easy, will be more clear. 2-year history and losing 8 kilos through the 2 years with cancer. I don't think so, and I can't agree with. I'm not agree with this answer. By the way,
There is
I can agree.
There is another
Sorry.
question. There is another question like this, but the explanation, because it is make long time, so it is not a carcinoma.
It is a stricture.
Yes.
A benign stricture happens from gastroesophageal reflux, from Barrett's, from achalasia.
Yes.
Okay, but just 2-year history, and the last 2 questions was 5 to 6 weeks progressive dysphagia, and even he didn't mention loss of weight, but 8 kilograms over 2 years, because he said she has lost a total of 8 kilograms in weight over this time which is the last 2 years. So
Yes.
it's not very common to be a carcinoma, by the way. Okay, I'm not agree with these questions. I'm not agree with this.
Yeah.
Sorry?
It's a vague question. It's not clear.
No. Yes. Dr. Nuran?
I wanted to ask about the weight loss. 8 kilograms over 2 years, that's not a lot, right?
We don't know what it is, not a lot or not a lot. He should tell you the percentage, or he tell you she was 70 and now she 50 and then now lost 8 kilograms. So patient has cough. Okay, patient has cough from gastroesophageal reflux. Is very common to have pulmonary respiratory problems like laryngitis and tracheitis. Very common with gastroesophageal reflux disease. Possible mets. The history is over 2 years. Don't convince me to be a carcinoma. يعني don't try to convince me. I'm trying to read the question many times again. May I miss one keyword, but there is no keyword.
What they mean is that she did have Barrett's or esophagitis, and then on top she developed carcinoma. And I think
okay, it should be more clear. It should be all patients have Barrett's or achalasia.
That much to me. That's why.
All patients have achalasia or GERD. Sometimes they lost weight from the 2 years history of problem, especially when he tell you she have cough. If you didn't see a patient have GERD with cough, really it's a very yes, it's a very serious problem. Cough with GERD is a very serious problem, and I know many patients with this. They can't sleep. They lost weight over 3-4 months from chronic cough. They can't eat. Okay, so let's pass this question, and I didn't see before and recalls, or not a very common question, by the way. The question will be more clear. Trust me, the questions are very clear in the exam, not confusing. Yeah, go for the next question, Dr. Ibrahim.
Okay, 60 years old man present with dysphagia And on investigations found has stenosis insert tumor of mid-esophagus with single metastasis in right lobe of the liver, segment 6. This is what is the most appropriate treatment. Radical
Okay, without reading the question, the answers.
stenting. I will say about
Exactly.
stent.
Insertion of a self-expanding metallic stent.
Yeah.
Okay. So the scenarios are very clear.
Yes.
Cancer esophagus with mets, cancer esophagus without mets, with narrowing. Okay?
Okay.
Yeah.
And that's what the UK wants you to know. He don't want you to be an expert oncologic surgeon. He just wants you to diagnose from history, and you will know this in part B, inshallah, when you pass, that he just wants you to know the broad idea about a patient, to take history, and this patient has mostly cancer, no, mostly GERD, mostly peptic ulcer, mostly IBS, mostly irritable bowel. He just know broadly, so you can direct the patient to the right specialty. Okay, next question again, Dr. Nuran. Go.
A 72-year-old man is admitted with an episode of brisk hematemesis. Following resuscitation, and upper GI endoscopy is performed, and the prominent blood vessel is identified in the mucosa approximately 6 centimeters from the OG junction on the lesser curve of the stomach. What's the most likely explanation for the bleeding? A. Gastric cancer. B. Portal gastropathy. C. Delafoy lesion. D. Linitis plastica. E. Gastritis. Upper GI, 6 centimeters from the OG. A gastric cancer?
Something like syndrome. A gastric cancer, you find a blood vessel in the mucosa. Is it a cancer?
Again?
Okay. What's he found in the endoscopy? A blood vessel in the mucosa. So just go by exclusion.
I think with this age group, the ulcer could be
no ulcer. What is the ulcer?
The source of the hematemesis.
There is no ulcer. For the hematemesis from a blood vessel in the mucosa.
By exclusion, C.
By exclusion, yes. Okay. By exclusion. Is it cancer? No, it is not cancer. So A and E is wrong. A and D is wrong. Okay. It is gastritis. No, gastritis comes more generalized, and hyperemia, generalized hyperemia in the stomach mucosa. It will not be a blood vessel. Okay. So it is just clear that it is something like syndrome. Portal gastropathy? No, it is not portal gastropathy. Portal gastropathy will be multiple blood vessels, dilated veins mostly, or dilated blood vessels, multiple. So by exclusion, Delafoy lesion, and this is a syndrome or a case. Just know it like this.
What's about? I just to read to remember what is the lentis plastica.
Linitis plastica.
Yeah.
This tumor infiltrating the gastric wall with narrowing of the lumen.
Okay, thank you very much.
Okay, it's one of the 4 types of gastric cancer, laser bottle, exactly. It's an infiltrative, highly malignant, infiltrative malignant tumor of the stomach that converts the stomach to a tube-like or a bottle-like organ. Okay, and the other one is ulcerative and cauliflower and fungating mass, or fungating, ulcerative, and linitis plastica. This is the 3 main tumors. I think there is 1/4 one. Ulcerative, fungating or adeno, and linitis plastica. I think they are 3. They have 2 classification for cancer stomach. You will face in part B. Next question. Whose turn? Whose turn? Dr. Fatima, okay, go.
A 55-year-old man is reviewed 3 months following a distal gastrectomy and gastrojejunostomy for carcinoma of the gastric antrum. He complains of symptoms of dizziness, palpitations, sweating, and occasional collapse after big meals. What is the most likely explanation for this presentation? Increased release of insulin. We discussed it.
Yeah,
Yes,
they
so
delay
it's dumping syndrome. Dumping syndrome.
Yes.
Okay. Dizziness, palpitation, sweating, and occasional collapse. The first 3 is dizziness, palpitation, sweating. It is a symptom of hypoglycemia, or on the occasion collapse, it is hypoglycemic triad. About sometimes you found it in insulinoma. It is dizziness, palpitation, sweating, and collapse. This is a triad of hypoglycemia. Okay, so it is increased release of insulin, followed the passage of high glucose content of the gastric contents to the jejunum. Next question, Dr. Dafer.
56 years old man presented with the adenophagia and squamous cell carcinoma of the upper third of the esophagus. Staging investigation and with the most appropriate course of action. Segmental resection of the proximal esophagus, radical radiotherapy alone, combination radiotherapy and chemotherapy, over Lewis esophagectomy, photodynamic therapy. I prefer to radical combination of the chemo and radiotherapy. It's either chemo radiotherapy or radical radiotherapy alone. I choose this one because it's proximal.
There's no metastasis.
Why not
Therapy alone.
for surgery?
Yes.
No metastasis.
Yes. For esophagus, especially for esophagus, you can do B or C. Over Lewis, no. It's B. It's C.
B.
C. Okay, so it is an carcinoma of the upper third. Okay, so you go for radio and chemotherapy. No
Yes,
radical.
No, because for esophagus, it is special for esophagus. Squamous and upper, it's maybe radiotherapy.
Perfect. I just want to hear squamous cell carcinoma. It's most commonly a squamous cell carcinoma, upper third of the esophagus. He wants you to guess that the tumor is squamous, mostly squamous cell carcinoma, and it responds to radio and chemotherapy. And it's not very common to do an operation or esophagectomy for an upper third gastric. It is common. We can do it, but it's not common. But the upper third cancer esophagus, squamous cell carcinoma respond for radiotherapy and chemotherapy. Okay, segmental resection, no. Radical radiotherapy alone, no. Even though it's just this is for lower tumors because it is a thoracoabdominal or just lower esophageal. Okay, photodynamic therapy, no, as well.
So we should remember 2 ends. In the beginning of the esophagus, it is start with the anal end. It is treatment.
Squamous, yes. Upper third of the esophagus is squamous.
Yes.
And the lower third will be normal esophageal mucosa.
Yeah.
Not squamous, okay?
Yeah.
Next question, Dr. Ibrahim.
Okay. 8 years old lady is being investigated for dysphagia following duration, and esophageal dysphagia is attempted. The procedure is complicated and there is significant difficulty in intubating in the esophagus. Eventually, the procedure is abandoned, and the patients turn to the world.
Cancelled.
Yeah. Here it is noted that the significant amount of surgical emphysema is present. Which of the diagnoses listed below is most likely to explain this presentation? Globus, Barrett's, esophagus, carcinoma, pharyngeal pouch, and it's pharyngeal pouch.
Exactly.
It's
Difficulty in intubation. So you are going through so the endoscope is mostly going through a false passage and can't go for the normal passage, and it just need an expert to go for the normal passage of the esophagus. And the patient, he tried many times, and the patient most commonly complicated with perforation, and that's why the patient has surgical emphysema in the neck, mostly because you perforated or you injured the pouch. Okay?
Yeah. Okay.
Clear for all?
Yeah.
Okay. Next question, Dr. Nuran.
A 45-year-old man has a 4-week history of epigastric discomfort, which is relieved by eating. He develops hematemesis and undergoes an upper GI endoscopy. An actively bleeding ulcer is noted in the first part of the duodenum. What is the best management? A, Whipple's procedure. B, truncal vagotomy and drainage. C, distal gastrectomy. D, injection of tranexamic acid. E, injection with adrenaline. Injection with adrenaline.
Perfect. I think we answered these questions many times before. Injection with adrenaline is the first step, and if failed, we will go for
Laboratory and running the picture of the ulcer.
Okay. Okay. Exactly. So next question here is not
Which of the following?
very common for okay, Dr. Fatima, go.
Which of the following patients should be referred for the first-line pediatric surgery? BMI 30 kg per meter square and hypertension, BMI 28, BMI 35 and type 2 diabetes, BMI 32 and BMI 70, COPD and type 2 diabetes. I'll go with one. No. C.
C.
What?
It's like 35 to 40 with comorbidities is what I remember.
You just need someone who works. And by the way, in not a very common question in the exam, because not all are bariatric surgery is a highly specified branch and need some and every day there is changes, and the BMI with the comorbidities depend. The operation depends on the BMI together with the comorbidities, and they have many scores about this. But roughly you do operation for bariatric surgery if BMI more than 40, or if more than 35 combined with a comorbidity like hypertension or diabetes, type 2 diabetes, specifically in a young patient. Okay, so 30 and 28 and 32 all are wrong. Okay, 35 plus diabetes, or you can go or more than 40. 70 kilogram and COPD and type 2 diabetes, this patient, they have special protocols in treatment. You have to go for balloon first till the patient reduce weight till he reach 45, 55, 60 or 50 BMI, so you can go for bariatric surgery after. So the general protocol, more than 40 or more than 35 with comorbidities, which is diabetes or hypertension. Okay, just put this in your mind. Don't confuse yourself with many BMI scores or many diseases.
Okay.
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 Next question, Dr. Dafa.
A 73-year-old lady presented with the progressive dysphagia and is diagnosed with esophageal cancer and liver metastasis. Is located 8 centimeter to the gastroesophageal junction. What is the most following treatment with the most appropriate management? Insertion of the celestine tube, inserted of Mansur tube, inserted of self-expanded metal stents, photodynamic transhiatal esophageectomy. C. Insert of the self-expanding metal stents.
Exactly. Okay. I know. Talk about it again. Next question, Dr. Ibrahim.
What's the following statement relating to gastric banding for obesity is false? It is one of the safest anti-obesity operation, successful up to 5 to 55% of excess weight may be lost over 2 years. Excessively tight gastric band has increased risk of long-term complication associated with early cystectomy. Contraindication: patients with polycystic ovaries who are trying to conceive. Is false. I think what is the relation between polycystic ovary and the gastric
Exactly.
band?
If I have new question and I don't know, by the way, when he tell you choose what is the false of the following, okay, especially what is false of the following, and he give you some numbers, I'll not tell you it is always right, but it is mostly he don't want to confuse you with numbers. You are already confused with the 5 choices, okay, or the number may be sporadic or just completely different. So he tell me you about 90% this rate or about no this rate or something like this. But here, one of the safe gastric banding, successful 55%, I don't know, but I don't know. So I'll continue. Excessively tight bands make problem. Yes, exactly. We have seen many problems with tight bands associated with early satiety. Yes, exactly. Polycystic ovary and are trying to conceive. So if I have B and E, I'm confused. I think E will be more logic to be not related to the problem. Okay.
Yeah. Okay.
Just you will find many questions in the exam like this, by the way. That's why the average score is about 82, 80, 81, 82, 83, up to 85. So you have 15% of questions, which means it's about 45 to 50 question confusing for all people. Don't be shocked when you find many questions, it is confusing. You have 15% of questions confusing. It means about 45 to 50 questions in both papers, okay?
Okay.
Okay, next question.
A 32-year
Dr. Nuran.
A 32-year-old lady presents with dysphagia. She has a 10-year history of anemia secondary to menorrhagia and has been strongly resistant to treatment. What is the most likely underlying cause? A. Candidiasis. B. Globus. C. Squamous cell carcinoma of the esophagus. D. Adenocarcinoma of the esophagus. E. Plummer-Vinson syndrome. Menorrhagia. Something endocrine or
By exclusion. Is there in the history anything about candidiasis?
Don't think so.
Okay, I don't know what's globus. He put it in all the questions, so something confusing put it there. If anyone know it. Okay, squamous cell carcinoma.
Okay, maybe
maybe
syndrome. So it's a syndrome of
No,
menorrhagia.
globus is like a psychiatric kind of condition in which the patient do not eat at all. It's like occurs in young patients.
Yeah, so this is patient. Okay. So is this psychic problem? No. Is it cancer? No history of cancer here, and this is a young patient. So it will be the Plummer-Vinson syndrome, or what we say the esophageal web syndrome, and it's very common with anemia for a long time. What is called Plummer-Vinson syndrome or esophageal web. Sometimes in the choices it comes with esophageal esophageal web.
Okay.
Please, anyone has noise background can mute himself, please. Okay, so next question. Dr. Fatima.
The patient is suspected to have a pharyngeal pouch, which is the most appropriate investigation. Upper GI endoscopy with flexible endoscope, upper GI endoscopy with rigid endoscope, upper GI fluoroscopic swallowing study, esophageal manometry, and CT scan of neck. Upper GI endoscopy with rigid endoscope or fluoroscopic first?
No,
Yes.
fluoroscopic swallowing study.
Yes. Okay, endoscopy is a little bit risky in some, and he said here it is contraindicated. No, it is risky, and most esophageal pharyngeal pouch are discovered through endoscopy, by the way. It is accidentally discovered by endoscopy. So it is contraindicated if you know. But most cases you go, and I have seen one case with one of my friends, he go for upper endoscopy and he discovered an esophageal or an pharyngeal pouch, okay? So go first with upper contrast study, and then for definite treatment. No endoscopy, severe manometry is just for motility. CT scan of the neck, no. We don't go for CT in UK or MRI without passing. Less invasive and less cost effective investigations first. Next question for Dr.
40 years old man is reviewed in the clinical 6 months after a redo fundoplication operation for gastroesophageal reflux disease. He complained of the abdominal distension and bloat. Endoscope show patent gastroesophageal lesion and upper GI contrast show delayed gastric empty. What is the most likely explanation for this? Excessive release of the cholecystokinase, excessive release of the gastrin, damage to the vagus nerve, damage to the short gastric vessels, excessive release of insulin. E, excessive release of insulin.
So what's your answer?
It's excessive release of insulin.
No, it's
Read the
Vegas.
question again. Read the question again. Read the question again. Endoscopy shows the patient.
Just a minute.
Gastroesophageal junction and GIT studies show delayed gastric emptying.
Yes, damage to the vagus nerve. So okay.
Okay, you confused between dumping and you run for excessive release of insulin. I think so in my mind. This is
distension and bloating.
Delay in gastric emptying. It happens with delay in gastric emptying happens with damage to the vagus or any gastropathy, like diabetic gastropathy happens, vagus pathology leads to delay in gastric emptying. If I want to ask you what is the best medication to give this patient to improve the gastric emptying, what will you give?
Erythromycin.
Perfect. Yes. You're still concentrating. Okay.
We will be confused
so
after some time.
No, I'm just trying to connect together questions together. Okay. Next question to Ibrahim.
Okay. 40 years old, the lady present with gastric carcinoma of the greater curvature of the stomach. Her staging investigations are negative for metastatic disease. What is the most appropriate treatment option? Radical radiotherapy, subtotal gastrectomy, D2 lymphadenectomy with Rho and Y, subtotal gastrectomy, D2 lymphadenectomy, and anterior gastrogynecostomy, esophageal gastrectomy, sleeve gastrectomy. It is greater curvature. I think B, subtotal, no. Radical radiotherapy.
Go.
B, يعني subtotal gastrectomy, lymphadenectomy, and draw in Y. This يعني my answer, but I'm not sure.
Okay, so you choose this patient is fit for surgery. Okay,
Yeah.
so the last 4 answers are right. Okay.
Yeah.
Subtotal, esophagogastrectomy. We are going to esophagogastrectomy.
No.
What is this tumor?
No.
In the greater curvature. So it is more than 10 centimeters from the gastroesophageal junction. Okay. So we will go for partial or subtotal gastrectomy. So esophagogastrectomy is wrong. Sleeve gastrectomy.
For a pediatric surgery.
No.
This is a bariatric surgery. So we have 1 and 2. As for most of candidates, sometimes most of them are non-surgeon. Anterior gastrogynecostomy is not a very common practice to do, and Rho and Y is the best treatment for any gastrectomy we do. Okay, any gastrectomy, distal gastrectomy, or if we do total gastrectomy, like the previous question we have in the start, total gastrectomy or subtotal gastrectomy, we prefer to do Rho and Y reconstruction. Okay.
Okay.
Clear?
Clear.
Okay, again, Dr. Nuran.
An 82-year-old lady with long-standing Barrett's esophagus is diagnosed with a 1 centimeter focus of high-grade dysplasia, 3 centimeters from the gastroesophageal junction. What is the best course of action? A, endoscopic mucosal resection. B, photodynamic therapy. C, distal esophagectomy. D, total esophagectomy. E, radiotherapy. Barrett's 1 centimeter focus of high-grade dysplasia. We remove distal esophagectomy. No,
We remove all the esophagus.
High grade.
E, endoscopic mucosal resection. We discussed this before.
Yes, exactly. Endoscopic mucosal resection.
Yes.
Okay. Again, low grade.
Endoscopic mucosal resection.
Low grade.
Low grade biopsy.
Biopsies, 4-quadrant biopsies.
4-quadrant biopsies.
High grade.
Endoscopic submucosal resection.
Or T1. Endoscopic mucosal. EMR. Endoscopic mucosal resection. Submucosal resection. Okay. Invasive or invasive cancer.
Even the age?
What?
Does age matter?
Invasive cancer. Without med stent means stent. With med.
With med.
With med stent.
Metallic.
Yeah.
Metallic stent. Okay. Without operation surgery.
With operation surgery.
Surgical esophagectomy. Okay.
But
this is in low. This is in low esophagus. If we go for high or upper third,
Radio and chemo.
radio chemo. This is all scenarios you have in for endoscopy, okay?
Okay.
For esophagus. Clear?
Clear.
Clear. Okay.
Okay.
Okay. Next question. Who? To Fatima.
Yeah. Which of the following procedures is not performed for obesity? I'm stuck with obesity. Okay. Sleeve gastrectomy, gastric bands, intragastric balloons, McQueen procedure, small bowel bypass. So it's, I don't know what this procedure is, McQueen procedure.
Yes, you know operations for obesity.
Yeah, but like I don't know this one.
Okay, exactly. So by exclusion, this one, sleeve gastrectomy, gastric banding, gastric bypass, gastric balloon, small bowel bypass, or these operations for obesity. McQueen, this is an operation for middle third or upper part, the middle third or the upper part of the esophageal cancer. McQueen, okay.
Esophagectomy.
Sorry?
It is a total esophagectomy.
Yes, but just we just talking about a cancer high,
Okay.
because if it is low cancer, we go for sometimes transhiatal or evoluis. Okay, so we use it for this approach is cancer from the mid esophagus and higher. Okay. Next question, Dr. Dafel.
Which of the following variability is not included of Rockall score? Congestive cardiac failure, liver failure, systemic blood pressure less than 100, aspirin usage, and age. Which of the following variable?
Do you know Rockall score?
I didn't remember. It is congestive cardiac failure.
Okay, this is a score for upper GI endoscopy assessment for patient.
Yes.
Okay, so let's go for the answer. This is aspirin.
Aspirin. Okay.
Not common question in the exam, and a question that has no relatives. Just know the ABCD for Rockwell. Put it in your mind. When you read it in the revision 1 or 2 times more, you will put it in your mind, and this is a question will come if it comes. Okay, this is how to assess the patient following upper endoscopy, or a patient for upper GIT hemorrhage for endoscopy. Age, blood pressure, comorbidity. What is the diagnosis of bleeding and evidence of bleeding? That's all, but aspirin is not included in the score. Go for the next question again, please.
Okay. 42 years old man presented with epigastric pain. At the end of the endoscopy, he is found to have a punch-out ulcer on the anterior wall of the stomach. It's shallow and measure 1 centimeter in diameter. What is the most likely?
What's your diagnosis?
Malignancy.
No.
Where is malignancy in the situation?
Just acute peptic ulcer. Acute peptic ulcer. Sorry.
Yes.
It is 1 centimeter in diameter.
It's acute peptic ulcer.
Okay, I told you we have 3 scenarios. We will see 2, and I expect the third may come. 1 with fibrosis, ulcer with fibrosis, and 1 ulcer without fibrosis, and 1 ulcer with constitutional symptoms of malignancy. Okay, so this is an acute peptic ulcer.
Yes, yeah. It's shallow. It's mean shallow.
Yes, shallow and no fibrosis. He didn't mention fibrosis. Okay, you see, even in the comment, absence of fibrosis coupled with small size is acute. The last scenario was 2 centimeters and fibrosis, and it was chronic. And I guess it may become scenario like punched out necrotic floor, bleeding, and loss of weight, anorexia, and something like this. It will be cancer or malignant ulcer. Okay.
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 Next question, Dr. Ibrahim.
20 years old man present with a 5 months history of episodes in retrosternal chest pain together with episodes of dysphagia to fluids. Upper GI endoscopy performed and no mucosal abnormality is seen. What is the most likely diagnosis? Mutated disorder, leiomyosarcoma, gastrointestinal stomach tumor, squamous cell carcinoma, benign peptic structure. It's mutated disorder.
Exactly. No abnormality through upper endoscopy. Leiomyosarcoma, you will find abnormality. Tumor, squamous tumor or guest, you'll find abnormality. Squamous cell carcinoma, you find abnormality. Benign peptic ulcer, benign peptic structure, you will find abnormality. So here's the question is simply, I think it's some, it is not nice question to tell you, I found no abnormality. So what is the abnormality? And give you some abnormal results. I think so. Motility disorder is our answer. Okay, Dr. Nuran, go.
Which of the following criteria is not an indication for bariatric surgery to be performed in the UK National Institute of Clinical Excellence guidelines? A, patients must be non-smoking for at least 1 year. B, patients must have tried conservative management for at least 6 months. C, commitment to long-term follow-up. D, surgery to be performed in a specialist unit. E, BMI over 35 kilograms per meter squared and hypertensive. I think B, surgery to be performed in a specialist unit, although smoking for at least 1 year.
Let's go by exclusion. Let's go by exclusion. Okay. What you know about bariatric is a BMI, yes?
Yes.
Is BMI 35 plus hypertension is an indication?
Yes.
Yeah.
Yes.
Yes, okay. Surgery to be performed in a specialist unit?
Yes.
Yeah.
I think yes, you have to go for the bariatric unit, even in Egypt now, in Cairo University or in Shams University, you have a bariatric unit. Okay.
Okay.
Commitment to long-term follow-up. It is one of the first indications, and you have to insist with this with the patient. Will you follow up with me? If he will not follow up with you, don't go for the operation. Okay, the patient should stick with you about 1 to 2 years, every month, every 3 months, every 6 months, every year, for many years, because you have to treat complications and try to replace deficits in his minerals, in his vitamins, and everything he will suffer from. Okay, so the patient, okay, someone please can, okay.
Answer is
commitment to long term, it's okay. Patient must have tried conservative management. Yes.
Yeah.
Patient should try conservative management. One of the indications of bariatric surgery is failure of conservative treatment, and it's must for some patients. Okay, and not to be smoking. No, I don't think so.
This is
smoking.
Anesthesia.
Anesthetic complications. So by exclusion, we'll go for
A.
At least A. Okay. Nice. Okay, Dr. Fatima, go for next question again, please.
A 58-year-old man with a long-standing Barrett's esophagus is found to have a nodule on endoscopic surveillance. Biopsies and endoscopic ultrasound suggests this is almost a 1 centimeter foci of T1 disease in the distal esophagus, 4 centimeter proximal to the esophagogastric junction. What is the most appropriate course of action?
Okay, what's your treatment?
So T1, and there is no mats, so EMR.
Exactly, perfect. As you said, T1 is a high-grade dysplasia, or it is the next step after the high-grade dysplasia. So endoscopic mucosal resection is the best treatment option here. Okay, Dr. Duffer.
34 years old HIV positive man referred to the surgical unit, surgical outpatient department with the jaundice and abnormal liver function test as followed. Albumin 34, alkaline phosphatase 540, bilirubin 77, TLS 45. What is the most likely diagnosis? Hepatic abscess, fungal obstruction of the bile duct, duodenal adenoma, primary biliary cirrhosis, sclerosing cholangitis. So it is primary sclerosing cholangitis.
Okay.
Yes.
HIV is not associated with primary biliary cirrhosis? No?
I hear either D or E, but I will do, because ALP it is very high, it's maybe D or E. It's E. It's E.
What's your
E.
what's your opinion about the analysis or the test here?
What? Excuse me?
Interpretation of this blood test or liver function.
Yes, it's albumin is low.
Yes.
Alkaline phosphatase is very high. Bilirubin also high. LTA,
Yes.
ALT, it's I don't remember.
It's high also.
Oh, high.
It's about 22, I think. It's about 22. Yes. Okay. By the way,
there's the video for sharing. Yes. Okay. Thank you.
okay. By the way, any results of lab in the exam mostly will give you the standard and the normal values. Okay. So don't be confused with this value. This here alkaline phosphatase looks so high. Bilirubin is high because he already told you, Jones, and he tell you this is abnormal liver function test. But he just want to tell you this problem has alkaline phosphatase high. And alkaline phosphatase is very common with bile, biliary system, problem, especially cancer or cirrhosis, okay? Because alkaline phosphatase mainly come from bone and biliary system. And both of them, any problem in the bone, especially cancer, or in the biliary system will make alkaline phosphatase so high. Okay, so we have primary biliary cirrhosis and sclerosing cholangitis. As a back history of HIV, it is very common to be associated with sclerosing cholangitis. Okay. Primary biliary cirrhosis, you will find many scenarios about it concomitant with inflammatory bowel disease and especially Crohn's disease. Many questions in the record, many questions and recalls talking about a patient have inflammatory bowel disease or Crohn's disease, okay, and the patient have a hepatic problem and jaundice. What's your interpretation, or what's your opinion, or what do you think of the disease? It will be primary biliary cirrhosis. Okay.
Yes.
And what is the test for primary biliary cirrhosis? We will go for, by the way.
Liver function test?
Anti-mitochondrial antibody.
Okay.
Anti-mitochondrial antibody, okay? This is in the recalls, and I don't know where we'll face it. Maybe face it in oncology or pathology, but anti-mitochondrial antibody is the main investigation for this problem. Okay, next question. Dr. Nuran.
Okay.
A 24-year-old man presents with dysphagia that occurs intermittently, and swallowing of both liquids and solids can be difficult at times. An upper GI endoscopy is unremarkable. What's the most appropriate next step? It's a motility disorder, so the esophageal manometry.
Exactly. So next step will be esophageal manometry. We will not go for operation. Our first one is Heller cardiomyotomy. What is Heller cardiomyotomy done for?
For ecclesia.
Perfect. Nissen fundoplication.
For the GERD, it is the 30.
Okay.
Nothing for GERD.
Injection of botulinum toxin. Botox.
It is
Ecclesia.
also for ecclesia, medical treatment.
Ecclesia.
Exactly. In spasm or for ecclesia. And we are going for manometry because if we done an investigation and it doesn't give us any results, we can't go for operation without diagnosis. So we go for next step or diagnosis. Even pneumatic dilatation. For what we do it?
Pneumatic dilatation for pictures.
Okay, for benign stricture, please be clear. Pneumatic dilatation is for benign stricture. Maybe post-infection, maybe post-corrosive, maybe post resection anastomosis. Okay, so or trauma and injury and suturing. Any benign stricture, you'll go for pneumatic balloon dilatation. Okay.
Okay.
Next question.
52 years old man with a long-standing Barrett's esophagus is diagnosed with high-grade dysplasia on recent endoscopy. The lesions are multifocal and mainly distally sided. What is the best course of action? Okay, so high-grade dysplasia is again, oh, there is nothing, okay. Basically, it's not, EMR should be there, otherwise esophagectomy.
Yes, exactly. Esophagectomy. We said high-grade Barrett's esophagus diagnosed with high-grade dysplasia of recent endoscopy. Okay.
Maybe because it's multifocal.
There is no EMR. Yes, it's multifocals. Yes, clear. It's multifocal. We do EMR maybe if you 1, 2, or 3 masses. You see, you can go for endoscopic mucosal resection. But if it is multifocal, you have to go for esophagectomy. Okay.
Okay.
Okay. So it is if we have just one lesion, and he tell you it is one lesion about 1 centimeter or 1.5 or maybe 2 lesions, you can go for endoscopic mucosal resection. But multifocal, you can't demycose all the esophagus by endoscopic mucosal resection. Okay, next question.
42 years old woman with no multiple gastric ulcer attends surgical outpatient unit. She has not improved despite 2 months of proton pump inhibitor treatment. She is found to have gastrinoma, which is the following false in relation to her diagnosis. Most commonly found in pancreas, No, gastrinoma not in pancreas. So
Okay,
it's
most commonly found where?
gastrinoma is a duodenum.
Yes,
I see.
perfect. Most commonly, gastrinoma is found in the duodenum. If we can read here, most common, about 50% you can find it in the duodenum, 20% in the pancreas, and rare places like stomach, spleen, and gallbladder, and so on. Okay.
Yeah.
So gastrinoma, most common in the pancreas. Okay, next question.
You can go. Okay. Which of the procedures listed below most strongly associated with delayed gastric emptying? Posterior gastrostomy, pyloromytotomy, pyloroplasty, anterior gastrostomy, Roux and Y gastrostomy. It was delayed gastric emptying. Delayed gastric emptying. No,
Okay, just go by exclusion. We will go by exclusion. Okay, posterior gastrogenostomy, no, I don't know because I have posterior and anterior, and I don't know the difference between. Pyloromyotomy, I think this is one of the operations we do for improvement of the drainage. Improvement of the drainage, to improve drainage. Pyloroplasty, the same, improve the drainage. Roux and Y, this is the most effective treatment in any resection, and this is the best operation for good drainage and good pathway of the food. So I just have to posterior or anterior. If I don't know, I choose anyone. But just put in mind that anterior gastrojejunostomy is the one associated with low or delayed gastric emptying. Just one of these answered, and if you don't know, just choose anyone and it will come by luck. But here is anterior gastrojejunostomy. Okay, try to go by exclusion to make the high rate of your answer maybe right or something. Anyone has noise background, please mute himself. Okay.
Okay.
Next question.
A 63-year-old man undergoes a total gastrectomy for carcinoma of the stomach. Which of the sequelae below is least likely to occur? A. Metabolic bone disease. B. Bile reflux. C. Dumping syndrome. B. Zinc deficiency. E. B12 deficiency. Total gastrectomy. Zinc deficiency.
Exactly. Metabolic bone disease happens with any gastrectomy. Bile reflux, yes, happens because we remove the stomach, so the reflux will be more. Dumping syndrome, we said it's a very common problem after gastrectomy. B12 deficiency because we removed the intrinsic factor, and still zinc, and zinc is more absorbed in the duodenum and jejunum. Zinc absorption happens in the duodenum and jejunum. Okay. Next question.
34 years old women. Sorry, it's not my turn.
Who's there? I can't remember.
Start then. 34 years old women with morbid obesity is referred for consideration of bariatric surgery. Which of the following options is associated with highest long-term failure rates? Gastric band, intragastric balloon, Roux and Y, sleeve gastrectomy, duodenal switch.
Okay.
Gastric band?
No. This is a big problem between surgeons and gastroenterologists, by the way. This is a big problem. And this is a big problem. And they fight and they sometimes kill each other because of this problem. So what do you think? What is the answer?
It is
like Roux and Y is best, so just leave this one. Then gastric band and intragastric balloon. In between these two.
What is the operation or what is the procedure done by the gastroenterologist, and he can't do any other operation?
Sorry, didn't get the question.
Balloon is done by gastroenterologist.
Okay. Balloon is done by gastroenterologist, or gastroenterologist doing upper endoscopy or lower endoscopy. They like to put a balloon. They don't look for any indication for any patient. Okay. So, and this is a big problem between the bariatric surgeon and the gastroenterologist. Take any patient without a choose may, the patient is not candidate for balloon, and the patient is a candidate for operation, and they convince the patient that he needs a balloon for sometimes, and he will be nice, and why to go for surgery and risks of surgery, and give him the balloon. The patient takes the balloon for 6 months, and within the 6 months, the patient is very nice and losing weight. As he removes the balloon, he comes more than the start. He have a rebound obesity more than he was. Okay, and this is a big problem between us and gastroenterologist. Please send patient for evaluation, and if he is candidate for balloon, we will send him back. I'm not telling all gastroenterologists. Some gastroenterologists can direct the patient directly, and some patients need balloon before surgery. And now the only and the most common indication for balloon, intragastric balloon, is it is a bridge before the definite bariatric surgery. Okay, so if the patient is 45 or 50 BMI, we give the balloon to make him less, about 40, 42, 43, and then go for bariatric surgery afterward. Okay, I think you will not forget it again.
Yes.
Yeah.
Okay, next question, Dr. Daffer.
A 56 years old lady presented with a 6-month history of dysphagia to the solid. She has a long history of the retrosternal chest pain that is worse on the lying flat and bending forward. She undergo upper GI endoscope where the smooth structure is identified. What is the most likely diagnosis? Globus adenocarcinoma, leiomyoma, benign structure, squamous cell carcinoma. It is a benign structure.
Okay, long history, 6 months. Okay, and retrosternal pain on worse on lying flat. This means she has GERD.
Yes.
Okay, and bending forward, and then upper endoscopy find a smooth structure. So it is a benign structure from long-term GERD. So it is a benign structure. I think we can see the difference between this clear scenario and the other scenario of 2 years of difficult on dysphagia and losing weight, 8 kilo through the 2 years, and he then choose carcinoma, and it is just not clear situation or not clear scenario. Okay, so this scenario is so clear. This is a benign structure. Okay.
Okay.
Last question, I think so, Dr. Ibrahim.
Okay. 45 years old man admitted with hematemesis. Upper GI endoscopy is performed. Large ulcer in the first part of duodenum is noted. Attempt to make endoscopy clip and inject the ulcer with bleeding previously. This effort is unsuccessful. What is the most appropriate management option? I will go to laparotomy and underrunning of the ulcer. C.
Perfect. Yes, perfect. Exactly. Okay.
Yes.
We finished the questions. Thank you. I'll close the recording, and if anyone wants to discuss or ask about anything, you are welcome.
Yeah.
Okay.
I want to ask about vitamin K is mainly absorbed by terminal ileum or absorbed mainly in the colon. As one question asked about what is the disorder about vitamin K, and the correct answer is mainly absorbed by terminal ileum and defected with resection of terminal ileum. Really, I'm become confused. Yeah, is
I think so. So
it's a Fauzi sheet.
Fauzi sheet.
Mm.
I'll just revise again and make sure, because most question about vitamin K, he is talking about the fat malabsorption will affect the absorption of vitamin K, but where is exactly? I think I have read one of the recalls talking about the site, maybe terminal ileum. I'll just check and make sure for you and answer you. Okay.
Okay.
I'll close the recording. Stop.